Now, Dr. Stephen Hunger, Children's Hospital of Philadelphia, USA.
It's a pleasure to speak again. I particularly want to say how nice it was to visit the Children's Hospital and see how impressive the developments have been there over the past few years and how much more impressive I'm sure they're going to be in the coming years. Okay, so this afternoon I want to talk about updates on the treatment of Philadelphia chromosome positive and Philadelphia chromosome-like ALL in children. Now, I used the same slide this morning, and one of the key points I want to make is that these early events are the ones that I think are the most useful to target with precision medicine therapies. And when we talk about the Philadelphia chromosome and the other lesions I'm going to talk about, almost all, but perhaps not all, are likely very early or initiating lesions and hence good therapeutic targets. So I think everybody is familiar with the Philadelphia chromosome. Approximately 3 to 4% of childhood ALLs are pH positive. It gets more common as you get older in adolescence. Age, white count, and early response are important prognostic factors in Philadelphia chromosome positive ALL. And prior to the use of targeted therapy with tyrosine kinase inhibitors, the outcome for this subset of ALL was extremely poor. And this slide just summarizes 2 studies from the Ponte-Delanio group that simply gathered information on how children with pH positive ALL did. They were treated in a variety of different ways by 13 groups. But these are data all from prior to the advent of tyrosine kinase inhibitors. Here we have 326 patients treated between 1985 and 96, and 610 treated between 1995 and 2005. And generally, if you think about this era, patients tended to be treated with very intensive chemotherapy, with many undergoing hematopoietic stem cell transplant in first remission. Yet despite that, only 90% of patients went into remission at the end of the first month. Only a third of patients were alive without having relapsed at 7 years, and less than half of patients were alive at 7 years. So clearly, intensive chemotherapy and transplant is not the solution for Philadelphia chromosome positive ALL. It doesn't mean that some patients are not cured, but when you look at the whole spectrum of those patients, they still do quite poorly. And as the tyrosine kinase inhibitors, or TKIs, were developed initially for patients with chronic myeloid leukemia, obviously there was interest in applying them to patients with Philadelphia chromosome positive ALL. They were first applied in adults and generally used for short term as a bridge to stem cell transplantation. And monotherapy with TKIs patients had responses, but they were very short-lived. So the next step was to try to combine them with chemotherapy. And in pediatrics, I think one of the big steps has been combining them with chemotherapy, and as I will show you, avoiding stem cell transplantation. So one of the first large studies was the Children's Oncology Group 008 ALL 0031 study led by Kirk Schultz. This was a complicated study that's introduced imatinib steadily. But if you look at the last group of patients, the goal here was to start adding imatinib at the end of the first month of therapy, which I think is important. So the first month of therapy was with no TKI. They then received 2 blocks of chemotherapy, and the goal was patients who had an HLA identical sibling donor were to have transplant, and the remainder of patients were to continue with this intensive chemotherapy regimen without transplant. And when we looked at the event-free survival for this group, the 7-year event-free survival was 72% compared to historical controls treated earlier without tyrosine kinase inhibitors of only 27%. So I don't think you have to consult your statistician to see that these curves are different and that tyrosine kinase inhibitors clearly improved outcome. And now there have been a number of studies published by the COG in North America and by the SFAL group in Western Europe and several other sites that have my take on these is severalfold. First off, all these studies are relatively small. The number of patients involved in any of these studies ranges from 54 to 178. So small studies and wide confidence intervals on the outcome. When you look at the outcomes, to me, they are all more or less the same. Event-free survival in the range of 60–65% long-term, overall survival in the range of 70% to 80% long-term. What we've seen over time, and this is with both either imatinib or dasatinib, what we have seen over time is a decrease in the number of patients who underwent stem cell transplantation in first remission. The first SFAL study, 80% of patients had a transplant in first remission, so it's actually very hard to say much about that chemotherapy regimen other than it was very useful in getting patients to transplant. But only 20% of patients avoided transplant. And the other thing is that now when you look at more recent studies, we're down in the 15% range of patients undergoing transplant in first remission. And then following up on Seema's talk, going from all patients receiving cranial radiation to only patients with central nervous system involvement receiving cranial radiation. So I think we see that these results are clearly better than they were in the pre-tyrosine kinase inhibitor era, but there's still room to improve. Now this, I want to present our current study, which is a intergroup study between the Children's Oncology group and the SFAL group in Europe, chaired by my colleague Louis Silverman. And the goals here were, number one, to use imatinib as the tyrosine kinase inhibitor, because we didn't see any obvious differences between imatinib and dasatinib, and certainly when this study was being developed, imatinib was more universally available. And then to try to risk group patients into standard and high risk based on their response to therapy, as I will show you. In the standard risk patients, to randomize between two different chemotherapy regimens, the SFAL regimen and a more or less standard ALL regimen, hoping to decrease toxicity, and also for the high-risk patients who are poor responders, to take them to transplant and to test the feasibility of using imatinib post-transplant. So this looks at the study. So patients enter the study at day 15 of induction, and imatinib is started then. However, patients are allowed to start imatinib as soon as the diagnosis is made. And in fact, most patients are starting by day 4 to 5. So very early introduction of imatinib. Patients complete induction 1A and then proceed to induction 1B regardless of response, and then are assessed by minimal residual disease at the end of 1B, and that is the risk assignment. So patients who have low MRD, less than 5 times 10 to the minus 4, are called standard risk and undergo the chemotherapy randomization, and patients who have more than 5 times 10 to the minus 4 are high risk and are assigned to transplant. Now, interestingly, when we designed this study, we have projected that about 15% of patients would be high risk. We've enrolled about 150 patients to date, and it's actually only 2 or 3% are high risk. And this is very different in prior studies, and the only real difference is that most patients are starting imatinib very early. So it seems to me that the very early introduction of imatinib is very important in terms of response. And this looks at the randomization. So patients receive either the SFAL regimen or a standard COG-based regimen. And the goal here is twofold. First, the SFAL regimen is significantly toxic and is associated with significant treatment-related mortality. Secondly, it also has significant treatment interruptions that often lead to interruption of TKI therapy. So at least the hope behind this is that a less intensive regimen will lead to lower rates of treatment-related mortality and also perhaps lead to less TKI interruption. And only patients who have central nervous system, overt central nervous system disease receive cranial radiation. The high-risk patients are those with high MRD at the end, of the 1B phase, and those patients are recommended to go to hematopoietic stem cell transplant. Now, there's a recent Chinese publication that I think has provided us with some very interesting data. This was published just really last month in JAMA Oncology, and the Chinese group randomized 189 children with Philadelphia chromosome positive ALL to receive dasatinib or imatinib. Now, interestingly, the dasatinib dose they used is the one that's been used by St. Jude, 80 milligrams per meter squared per day, but is lower than that used by the SFOL and COG groups, which was 60 milligrams per meter squared per day. The imatinib dose is also a bit lower, 300 milligrams versus 340 milligrams per meter squared. And this study was stopped early, as you can see here, with a clear advantage to the dasatinib versus the imatinib arm. And I think that challenges the assumption that the two TKIs are equivalent. Now, I and many others have some questions about this study that I think longer follow-up is needed. First, the follow-up is relatively short, with a median follow-up of only 26 months. The results in the dasatinib arm look to be quite good, but if you look at them, they're very comparable to the results obtained by SFOL and COG with either imatinib or dasatinib. If you look at the imatinib results in this study, they're actually quite poor and much worse than seen in the COG or SFOL studies. So the question that remains here is whether dasatinib was better because the higher dose of this, because dasatinib at a higher dose is better than imatinib, or perhaps whether the imatinib dose is, whether the imatinib arm is unusually poor response. And there are some, the imatinib was commercial imatinib provided in, or available in China, and one could also wonder about whether there was any problems with the drugs. So at this point, the COG and the SFOL group are not changing their approach, but would like to see longer follow-up to see whether dasatinib should be used in these patients. So a lesson that can be drawn from the treatment of Ph-positive ALL is that the outcome of very high-risk ALL subsets can be improved dramatically without using stem cell transplant if there is a driver molecular lesion that is fundamental to the disease process, like the BCR-ABL fusion protein, and the leukemia is dependent upon the continued activity of this protein. And this is the concept of oncogene addiction. The cells are addicted to BCR-ABL. If you take BCR-ABL away, they die. So then if you have an effective targeted inhibitor that could inactivate BCR-ABL and can be combined with chemotherapy, then perhaps you can improve outcome. So this suggested to many of us that we should try to find other targetable lesions such as this in high-risk ALL subsets. So this led to the development of the Target project, which I mentioned earlier. And one of our initial discoveries was an entity that we called Philadelphia chromosome-like, or BCR-ABL-like ALL. This was described simultaneously, really, by two groups, the Target group with Charles Mulligan in 2009, and the Dutch Childhood Oncology group with Monique Den Boer in the same year. So it's defined by a gene expression profile that is similar to that of Ph-positive ALL, but BCR-ABL fusion is lacking, and this signaling profile looks like activated kinase signaling. The frequency increases with age, going from 10% in young children with standard risk ALL to 15 to 20% in adolescents with high risk ALL, and to about 20 to 25% in young adults. Genomically, it's deletions or mutations in the Icaros gene are common, as well as deletions or mutations in other genes encoding B-cell differentiation factors. And the genomics, so Philadelphia chromosome-like ALL is a phenotype, it is not a genotype. The genomics of this subset, at least as defined by the Children's Oncology Group in our patient population, which is ethnically different than that in Western Europe. About half of patients have rearrangements of a gene called CRLF2. Half of those patients have mutations in one of the Janus kinases genes, most commonly JAK2, and a significant percentage of the remaining patients have a variety of gene fusions that target ABL1, ABL2, CSF1R, PDGFR-beta, JAK2, and other kinase genes. And also these patients have a greatly increased risk of treatment failure and death. Now, in vitro, if you study these proteins in vitro, these are the so-called Abel class fusions that on the 3' end retain the tyrosine kinase domain of the Abel-like gene, ABL1, ABL2, CSF1R, or the platelet-derived growth factor receptor beta. They behave identical to BCR-ABL in vitro. So if you take factor-dependent cell lines derived from mouse B cells that require exogenous growth factor for growth. You have to feed these cells IL-3 or another growth factor for them to grow. If you take away IL-3, they die. If you transduce these cells with BCR-ABL, they are able to survive in the absence of IL-3. And if you transduce them with these molecules, the same thing, they can survive in the absence of IL-3. However, if you then treat them with, in this case, dasatinib, the cells die. So this suggests to us that these Abel class fusions phenocopy BCR-ABL and should be similarly responsive to targeted therapy with chemotherapy plus an Abel class tyrosine kinase inhibitor. And this just looks at the outcome. So this is a large study in the Children's Oncology group comparing high-risk patients without Philadelphia chromosome-like ALL to those with Abel class fusions, JAK2 fusions, or EPO receptor truncating rearrangements, or JAK mutations. And here, as you can see, all of them have a hazard ratio of around 3 for event-free survival and death. So all associated with a poor outcome. Now, one of the challenges in trying to treat these is that there are so many different fusion partners. So this is a review, Sarah Tazian, Lowe and I wrote now 2.5 years ago, and every time you write one of these, it's out of date because there are new fusion partners. But even at that time, 13 fusion partners for ABL1, 21 for JAK2, etc. So the diagnosis of these subtypes of leukemia is challenging. It's very easy to test for BCR-ABL, but it's much more complicated to test for this wide variety of different fusion genes. Now, in preparation for developing targeted therapy, we wanted to develop the diagnostic tools to do that and to learn how to do this in real time. So we underwent a retrospective analysis of 1,389 patients enrolled in a children's oncology group trial. And these patients either had NCI high-risk ALL or standard risk ALL with a poor response to induction therapy, having MRD positive at the end of induction. And 20% of patients with high-risk ALL had Philadelphia chromosome-like ALL, compared to 3.3% of those with Ph-positive ALL. So this is much more common than Ph-positive ALL. When you look at the CRF2 rearrangements, so patients who with Ph-like ALL and high expression of CRF2, 80% had rearrangements of CRF2, and they're divided half and half between rearrangements involving the immunoglobulin heavy chain gene or the P2RY8 gene. And of those with rearrangements, 45% had mutations in JAK1 or more commonly JAK2. When you looked at the cases without CRF2 rearrangements, we saw a variety of Abel class lesions with different 5' fusion partners, also the same thing with JAK2 fusions or EPO receptor fusions. And so from this, targetable lesions, or potentially targetable lesions, are present in 2/3 of high-risk ALL cases that have the Philadelphia chromosome-like gene expression profile. Some can be targeted with dasatinib or imatinib, and that includes the Abel class fusions. 14% of the Ph-like ALL, which was 4% of NCI high-risk ALL, So that's really the same frequency as Philadelphia chromosome positive ALL. And then a number that can potentially be targeted with ruxolitinib, which is a JAK2 inhibitor, and this includes the CRF2 rearranged cases and cases with JAK2 or EPO receptor fusions. We then went to ask, because almost all of our studies have focused on children with high-risk ALL, we wanted to ask, is this the same in children with standard risk ALL? So standard risk meaning those with a age less than 10 years, older than 1 and less than 10 years, and an initial white blood cell count less than 50,000. So we really did the same studies in a population of 1,023 patients with standard risk ALL. And here we found a very different genomic landscape. So of the patients who had a high CRF2 expression, only half had CRF2 rearrangements. Of those with CRF2 rearrangements, almost all of them were the P2RY8 CRF2 versus the IGH CRF2. And out of 1,023 patients, only 5 patients had kinase fusions, only 2 of which were Abel class fusions. This really was somewhat surprising to us. And so when we look at these differences in these groups based on NCI risk group, comparing NCI high-risk patients, NCI standard risk patients or MRD positive, to unselected NCI standard risk patients, we see a decrement in the rate of pH-like ALL going from 22% in the NCI high-risk patients to 17% in the standard risk MRD positive patients, to 14% in the standard risk unselected patients. We see differences in the rate of CRF2 rearrangements, and in particular, we see significant differences in the rate of Abel class fusions, 4% in the high-risk population, 1% in the standard risk MRD positive population, and 0.2% in the standard risk overall population. And then when we look at outcome, these patients were treated well before we even recognized this subset, so none of them had therapy altered based on this. And we see their event-free survival is somewhat inferior, although it's not horrible. 7-year event-free survival of 82% among standard risk pH-like versus 90% for standard risk not pH-like, and the overall survival really no different. Remember, the event-free survival was less than 40% for the NCI high-risk pH-like patients. So from this, we concluded that the prevalence of pH-like ALL is lower in children with NCI standard risk compared to high-risk ALL. The standard risk patients have few targetable kinase fusions and have improved outcome. And that told us that there was limited utility to screening all of the standard risk patients for these abnormalities. So based on that, we implemented 2 clinical trials where in real time we screened for the presence of pH-like ALL, and then in patients who had pH-like ALL, we did the downstream genomic characterization, and those that ended up with a potentially JAK STAT pathway abnormality were eligible for enrollment in a trial led by Saratazian that's testing the addition of ruxolitinib to chemotherapy, and those that had Abel class fusions were eligible for a study that added dasatinib to chemotherapy. This study has finished enrollment, but the outcome has not yet been analyzed, and this study enrollment is ongoing, so we don't have any data yet from that study. Now, what we are in the process of doing now is saying, since we think these Abel class fusions really act the same as BCR-ABL, let's treat them on the same trial. So we're in the process of amending the Philadelphia chromosome positive trial I mentioned to you earlier to include patients with Abel class fusions. Since it takes a little while longer to identify these patients, they will enter the study at the end of induction therapy, but they will be allowed to start imatinib at any time during induction when they are identified, and they will be treated and randomized in the same manner as the BCR-ABL positive patients. So I'd like to thank many people from the Children's Oncology group as listed here, and many people on the laboratory side as listed there, and I'd be happy to answer any questions. Thank you.
Thank you very much, Dr. Sleeman. The floor is open to questions. Yes, Dr. Theo.
Thanks, Steve, for another great talk. I have a question regarding, are there any guidelines in the COG protocol about dose reduction in patients who are receiving TKIs or drugs around the chemo? For instance, in maintenance, if the blood, if the counts drop, do you stop or go with both of them, or do you consider optimizing one versus the other?
Yeah, so the approach we've taken is to try to maximize the intensity of the TKI therapy. So the doses are continued regardless of blood counts unless the next phase of therapy is delayed by more than 2 weeks. If the next phase of therapy is delayed by more than 2 weeks, then the TKI is stopped until counts recover, and then is restarted at 80% dose. Investigators have the option to then escalate the TKI to full dose at their discretion. Again, we haven't proved that's correct, but our bias is that it is optimal to maximize the intensity of the TKI therapy.
Yes, Dr. Hanafi.
Thank you, Dr. Steve, for this great presentation. Actually, in my center, we are giving imatinib for 1 year post-transplant for Philadelphia post-transplant, starting 2 to 3 months after transplant for 1 year. And, we don't know how much the impact of the outcome for giving TKI post-transplant. And also, for those who are very slowly resistant, forcibly responsive to imatinib at the first line treatment and have persistent MRD in spite of imatinib, is it better to give imatinib or we can give dasatinib post-transplant?
Sure, so actually it's surprising that there's remarkably little data in pediatrics about the clinical utility of using TKI post-transplant. There are some data in adults, and they are conflicting, whether routine use of TKI or so-called preemptive use of TKI when MRD becomes positive. So that's why on our current study we decided simply to try to see if it was safe and feasible to use the TKI post-transplant. And there are at least theoretical concerns about the use of TKI post-transplant. TKI are being used currently for refractory graft versus host disease, and there are some concerns that TKIs might inhibit the graft versus leukemia effect. But the current study does recommends basically what you just indicated, which is to start after engraftment, which is usually at the range of day 50 or 60 post-transplant to unstable engraftment, not just an ANC over 500 for 3 days. Usually we require an ANC over 500 for 28 days. And then to continue for a year post-transplant and just collect data on the safety and feasibility of that. Now the second part of your question, if I understood it correctly, was if you have a patient who responded slowly to chemotherapy plus imatinib and therefore got a transplant because they were a slow responder, does it make sense to give them imatinib post-transplant when they didn't respond that well to it pre-transplant? And you raise a good point. If you look at pediatric Ph-positive ALL that relapses, only about 10% of patients have an actual TK mutation. So it doesn't appear that the relapses that occur in children with Ph-positive ALL are typically due to the acquisition of a point mutation that interferes with TKI therapy. It does happen, but it's quite uncommon. So for that reason, most people use the same TKI they used pre-transplant, which in most cases is imatinib, although in some cases dasatinib, but I agree that you raise a good point about whether that's the best approach.
Dr. Hussein.
So thanks for this very informative presentation. You showed very convincing data for the use of TKIs for Philadelphia-like. To my knowledge, that the next generation of protocols are not going to classify or separate or look for Philadelphia-like chromosomes unless they are MRD positive. Could you comment on this or clarify that specific point?
Sure. So I think there are compelling reasons to test TKI therapy in PH-like ALL. And there are large numbers of anecdotes of adding patients who have Philadelphia-like ALL with a specific genomic lesion respond poorly to chemotherapy and then have a TKI added and go into a good, solid remission. What there aren't to date is proof that adding TKI works. So I think it's going to, but that's a bias. That's not a fact. Our current approach in the COG with the ABO class lesions, as I mentioned, is starting to enroll them in the same trial, the same Philadelphia chromosome positive trial, and that's regardless of clinical risk factors or regardless of MRD response. In parallel, we've been testing ruxolitinib in the other subsets of PH-like ALL. I think the data supporting ruxolitinib are not as strong as the data supporting imatinib or dasatinib in ABO class lesions. So in that study, it was limited to poor responders because it's really a safety and feasibility study to try to prove that it's safe to give ruxolitinib. If it proves safe and we see an activity signal there, certainly you would want to give it to more patients. So that's the reason why it was limited by the COG to the MRD positive patients.
Any other questions?
Thank you very much.
Thank you very much, Dr. Steve.